So last lecture of the semester. Don't know about you, but I'm glad. Okay, we talked last time about psychopathology, psychological disorders, diagnoses. Today we will talk about treatment of psychological disorders. For better or worse, this is what I spend my days doing. I will do my best to constrain my enthusiasm, and I will try to keep this to what I would normally do the last class period of the semester. Generally speaking, I would talk about treatment of psychological disorders for approximately half the class, maybe a little bit more, and then end with that content early so that we have time for review and questions and so forth with the exam. If you're watching this video prepping for the exam, and I hope you are, if you have any questions, if you need anything explained, you can always avail yourself of the tutors in the Success Center. You can also send me an email and let me know what it is that you're needing some help with, and at least we can talk on the phone. Perhaps we can do a video chat of some sort and get things cleared up for you. All right, I hope you're studying. You should be studying daily at this point for the exam if you want to do as well as possible. We'll hit this, and today, what is it right now? Today is Wednesday, so we would normally be having class about now. I should have this posted by midday tomorrow for you, and I will set up. I'll send out an announcement detailing the exam, when the exam is going to be posted and how long it'll be posted and all that sort of thing. All right. So, as they say, without further ado, here we go. Fittingly, last class period, this is the final class period, the first class period of the semester, I talked to you about the father of psychology, the German guy Wilhelm Wundt, first journal, first lab, psychological laboratory. Also started the first modern psychological clinic. That was by no means the first effort by civilization to treat psychological distress in our fellow human beings. There is plenty of evidence in the ancient world of efforts that actually sometimes were surprisingly similar to what we do today in terms of psychotherapy, counseling, talk therapy. There's archaeological evidence of what appears to have been a psychiatric ward in a hospital in ancient, what is today Iraq. And the evidence that we have of what they were doing in that psychiatric ward is remarkable for frankly, how kind and gentle it was. We generally have this picture, if we think about it, ancient attempts, or even attempts outside of the last 150 years, we tend to think of psychological intervention as depicted most frequently in movies and television shows about historical time periods, and generally it's depicted as frankly somewhat barbaric, and to be fair, there were periods where it was pretty barbaric. But one of the things we tend to omit is that throughout the course of history, there were precursors to what we do now. Like I was talking about the archaeological evidence of a remarkably of a psychiatric ward where apparently the treatment practices were remarkably similar to the general spirit of the approach, the modern approaches. Similarly, the ancient Greeks used versions of talk to try to alleviate the suffering of their fellow citizens. We during medieval times and the Dark Ages, which, if you listen to modern historians, probably were not nearly so dark as we sometimes now perceive them. There were modern or early precursors of modern psychotherapy taking place in monasteries. It was not an unusual thing if somebody was struggling with a fairly significant mental illness, what we would now recognize as mental illness, what they would certainly recognize back then as distress and perhaps fairly disturbing behavior that might sometimes be mistaken for demonic possession or something like that. Well, those people were often taken to monasteries, places where Catholic monks and priests lived. And in those ancient times, those monks and some priests had some degree of expertise in distinguishing between run-of-the-mill psychological distress and actual demonic possession. The way that it's depicted in the movies often is that anybody outside kind of a small normal range was perceived as a witch or as being possessed or something like that, and that's frankly that's just false and kind of insulting to the people who lived back then. They were, of course, constrained by the technology and the knowledge of the day. They didn't know as much about the underpinnings of psychological distress as we do today. And there was certainly probably more superstition, and in particular more the assumption of more involvement in of the supernatural, specifically of angels and demons and these kinds of things. Admittedly, there was more of that back then. But then, like today, if you ever have the opportunity to talk to a Catholic priest who is an exorcist, take advantage of it. It's fascinating. I've had a couple of different conversations with different exorcists. And the one of them, both of them were well trained in psychological diagnosis. One of them actually had a PhD in psychology. Both of them had pretty broad medical knowledge, because one of the things that they are tasked with doing today and back in medieval ages and dark ages and so on and so forth is these priests and these monks that were involved in this process were trained to make a distinction between demonic possession and run-of-the-mill psychological distress. The thing that struck me in talking to the exorcists today is these are men of science, the priests, but they are people who have the guy with the PhD. I want to say his PhD was from Emory in clinical psychology. This is not this is a man of science in addition to being a priest. And he said the reality is most of the people that we get referred to us for exorcism do not need exorcism. They're mentally ill. They are psychotic. They have schizophrenia or a delusional disorder or something like that. And that there's just a mistake being made, and people around them for some reason assume that they're possessed. But interestingly, both of the priests said there are very clear instances that are not explainable by science, and that they regard as possession, which was pretty alarming to hear, frankly. But I'm saying all that to you to say, in medieval times, even back that far, there were people associated. The church that time was the Catholic Church, that were trained to help distinguish between somebody who was possessed and somebody who was just in very unfortunate circumstances and in psychological distress. And in those cases, generally what would happen is that they would be counseled. They would, the priests who, again, contrary to how they're presented often in movies, where they're not infrequently they're the villains in a movie. The reality is most religious people throughout most of history have been well-intentioned people, and they do try to alleviate the suffering. What prior to the modern age, the typical person in psychological distress generally got something approaching counseling or what would be as close to psychotherapy or psychological counseling today was consultation with their pastor, and prior to that with their parish priest. In fact, throughout most of Western modern history over the last 2,000 years, let's say, the Catholic Church was a fairly powerful force, and they required the sacrament of confession for all Catholics, which meant all Catholics would go after a certain age of childhood, would go and sit down with a priest on a regular basis and talk through the struggles they were having. And part of what goes on in that system even today is separating out what is sinfulness and what is distress, and those aren't always the same. Sometimes they coincide, but they aren't always the same. So for 1,000 years, easily, probably more like 1,500 years, that process was taking place and bore some passing resemblance to what we think of as psychotherapy today. But by and large, if somebody was suffering from madness, somebody was having significant psychological problems, there really wasn't a recourse. There wasn't an option to refer them to a therapist or to a psychiatrist or something like that, obviously, because those things didn't exist. And it generally fell to the family and the village, the small community in which the person lived. And like I said before, not infrequently, especially in Europe, to the parish, to the priests and the monks and the nuns that led those parishes to try to care for and remediate whatever distress the person was experiencing. As you moved closer to the modern age and we began to develop asylums, they initially weren't perhaps even predominantly for people with mental illness. They were exactly what they're described as, asylum, a place of safety and refuge. Again, often associated with some sort of religious denomination. They were places where people who were otherwise destitute, without homes, without options, would live. In some cases, they were places where people who had sufficient wealth and privilege would go to rejuvenate themselves. So it wasn't just a place that people who were suffering from significant mental illness would find themselves. These asylums were sources of comfort for other circumstances also. And I make the point in here that it wasn't until the 1700s that there was an incipient recognition that mental illness was a problem rather than a possession or a curse. That's not really completely fair. I would rephrase that, actually. I would say it wasn't until about the 1700s that you got broad recognition, not just among people who were relative experts. So we would be talking often in terms of pastors and priests and what would become physicians, people who were responsible for providing care for their fellow man. The general population often was suspicious of it and regarded it as evidence of sinfulness or possession. So what I'm referring to there is the general population. The reality is thoughtful, careful philosophers, theologians, physicians, and things related to physicians had known for eons, for generations, that there was more going on here than the supernatural. As you move into the 1700s, one of the things that we see developing is the Christian denomination of Quakers founded institutions of what they called moral treatment. And what they would do is they would, these were essentially asylums or psych wards, so to speak. But the focus was on helping the person cope with sinfulness in their lives. And this is interesting. The word sin, the origin of it means to miss the mark. And if you take a step back from religion and you separate out the politics and the personal investment and so on and so forth, what you have are human institutions that have been around for, in some cases, hundreds, but in most cases, thousands of years. In the case of Christianity, roughly 2,000 years, and an additional 4,000 years prior to that in its ancestor of Judaism. And a lot of it, there's a reason why we talk about Judeo-Christian beliefs. A lot of the Christianity originally was a denomination of Judaism. The first Christians were people who were Jewish. So we have this, 6,000 year history, let's say. And even if you disregard the supernatural, and even if you, to the degree that you can separate out the religiosity, what you have are systems of tradition, are systems of traditional wisdom, of wisdom that has been accumulated over thousands of years. And while the concept of sin is related to the supernatural, and certainly in Judeo-Christian perspectives, to God and heaven and hell and these kinds of things, there's a way of looking at religious belief in which the focus is really on the reality that many of these things are fairly pragmatic. And I'll give you, the best example, the common example is the Ten Commandments. You don't have to be a religious person to look at the Ten Commandments, especially after the first three, which have to do with God and your relationship with God. Subsequently, the focus is on how you're treating each other. Don't lie to each other, don't steal from each other, don't kill each other. And they're generally good guideposts for how to interact with people around you. A significant portion of most religious texts is focused on how do we get along with one another in a civilized society. And so what the Quakers were doing was they were basically taking their way of looking at the world, which is a religious perspective, and they were saying, if we can get these people to accept this way of living, they're likely to experience less distress. And the reality is, like it or not, no matter how you feel about religion, the data on religious practice is very clear. People who espouse religious beliefs and actively practice those religious beliefs tend to be physically healthier, psychologically healthier. They tend to report higher levels of happiness. They're more likely to get married and stay married. They're less likely to be drug addicted. They're more likely to be employed and stay employed. They have a higher average income, blah, 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 right? There's all of these variables. And the research into this suggests that this is because the expectations of somebody who is active in a religious tradition tend to be for things like self-discipline, consideration for others, a certain degree of selflessness, etc., etc. All things that tend to be a part of having a relatively happy life. So the Quakers had some degree of success in basically helping people recognize that there is a way that you can live a life that is more likely, if not to lead to happiness, at least to lead to some degree of meaning and purpose in life. So we think of that, we think of Quakers and institutions of moral treatment as kind of archaic and backwards, but it's not an unreasonable approach when you take a step back and you look at exactly what was going on. Okay, so moving a little closer to the modern age, we saw emerging the closest precursor to what we think of today as psychotherapy grew out of basically two channels. One, a guy named Mesmer, who had some theories about what he called animal magnetism. I guess you would say it would be similar to the Chinese concept of qi, that there's a life energy in people. And he believed that problems, psychological problems and physical problems, derived from this magnetism, this qi-like thing, being the flow of it being clogged, basically. And in the course of first thing he started out having people take iron and using magnets and all these things, and eventually kind of gradually shifted toward what would become his hypnosis, which is why mesmerism is, I don't know if it's synonymous, but it's a similar meaning to hypnosis. And that concept of hypnosis is similar to psychotherapy in the sense that the cure is achieved by talking to somebody. And one of the things that happened early on was that he had some success in treating what was called at the time hysteria, and which technically does still exist. It's just it's much rarer today than it was then. Hysteria was a situation where people would, generally females, would demonstrate apparently neurological symptoms that either were impossible on the basis of what we understand about how the nervous system works, or maybe were consistent, or others that were consistent with how we know how the nervous system works, but were not curable. The treatments had been tried and they couldn't help them. And Mesmer had some success with this. That drew the attention of two Austrian physicians named Breuer and Freud, Breuer an older man and Freud his protege, who were working with people who were suffering from things like hysterical blindness, what they called glove anesthesia, which would be where the hand would be numb basically from the wrist down to the fingertips, kind of like how a glove would fit. And this would be an example of one of those things that's not the way the nervous system is set up, right? You can have numbness, but if you have numbness that's nervous system based, it's going to run from the tips of these two fingers, for example, up the arm, right? You're not going to have numbness. There's no neurophysiological, there's a nervous system based way for you just to have numbness in your hand. Obviously there are some ways that it can happen. Like you sit on your hand and you cut off the blood flow for a little while, but this was sustained numbness in kind of a glove shape on their hand, glove anesthesia. And so the physicians, early neurologists, didn't know what to do with these people because nothing was working, and in some cases it didn't fit what they knew about neurology. And like I said, this Mesmer guy was having some success with hypnosis that attracted the attention of these two Austrian physicians, Breuer and Freud, Freud in particular went and worked with Mesmer and learned his techniques. He came back. He started out practicing something fairly close to the hypnosis that Mesmer was using. He got some limited success because hypnosis is actually a legitimate intervention. Hypnosis works for certain kinds of problems. Nothing magical about it. It's essentially a very deep state of relaxation in which the person tends to be more receptive to suggestion. So it can be effective. It's not a surprise that it worked for some things, but it wasn't significantly effective. But in the course of doing this hypnosis sort of a treatment, Freud, who was insatiably curious about what makes people tick, would do what physicians do, and he would do a medical interview. He would ask them all sorts of questions about their background and so on and so forth. And I'll give you an example of kind of how one of the early precursors of or what would become psychotherapy, what would become what Freud and Breuer coined the talking cure, is that example I gave you of glove anesthesia. A woman was referred to them with glove anesthesia. Neurologists are saying, you know what, we believe her, we think she's telling you the truth. She doesn't appear to have any reaction to pain or other sensation in her hand, but we know that this can't be a neurologically based symptom, so we don't know what to do with her. And so Freud was going to try hypnosis, did the clinical interview with her, and in the course of this clinical interview, which was pretty intensive, Freud being the curious and interested scientist that he was, asked her all sorts of questions about her background and her history and her current functioning, including things that, frankly, in the late 1800s were kind of off limits. And what he discovered, and you got to bear in mind the time period when this was the late 1800s, the kind of the Victorian age, right? So the sexual mores, the rules of society at this time in Europe in particular were very, very rigid. And there were very clear expectations about men and women and how they behaved and how they expressed their sexuality and so forth. And they were fairly, frankly, generally speaking, they were fairly restrictive, particularly for women. And long and short of it is what Freud discovered in talking to this woman and several others, all of whom had glove anesthesia, was that the glove anesthesia started shortly after they began masturbating. And this was not, putting it mildly, not acceptable behavior for a young lady in that time, in that place. And he saw this pattern, and a couple of things happened. One, he identified this pattern across several women with this same symptom. And the other thing he noticed is that he would be gathering this history, this medical history, and this would come up, and he was, contrary to how we sometimes think about him in the field of psychology, he was apparently a very warm and fairly kindly, little stiff, but fairly kind guy who actually did want to help his patients. And these women would, and he was a fairly liberal-minded man, in the sense that, think about this, in the 1800s, he did not perceive homosexuality as a mental illness or a defect. That was extraordinary at that time. We didn't declassify homosexuality as a mental illness until I think 1974 in the United States. So he was 100 years nearly ahead of his time. In terms of the way he thought about sexuality. And so these women would tell him this, and they would become tremendously distraught, and he would provide reassurance, and he would talk to them about it. He would talk to them about the nature of their distress, and that they feel terrible and they're all upset, And, he would intervene as a doctor, and he would say, this is a normal and natural process. This is something, it feels good physically. He would explain the circumstances to them and try to offer some comfort and support. And what he found was, in several cases, is that this talking through this symptom made the symptom go away. And he hypothesized what was happening was that the guilt that they had was so intense that the source of the pleasure, the hand with which they masturbated, would go numb, as if the person was disavowing the hand, as if the woman was saying, "This is not mine anymore," or "I'm not to blame for this. This is not part of me." And he hypothesized this, and then he would actually later on directly approach this with what he called an interpretation of what the symptom was about. And what he found is, as he began to interpret it directly, the effectiveness increased. He could remove this hysterical glove anesthesia, in some cases permanently, just by talking to them. So that's the kind of the origin of psychotherapy, the discovery that we could alleviate even physical symptoms sometimes by just talking. And what we're finding out today is much of what we thought. Well, what we're finding out today is there's the distinction between psychological and physical is false. Everything that goes on psychologically has physical origin in the brain, and much of what goes on physically with the body in terms of symptoms is affected by our psychological state. We know this indisputably. The evidence is very, very powerful. So, foundation of modern psychotherapy. Okay, so we have kind of a very, very, very brief and very broad history of psychotherapy. The first kind of modern version of psychotherapy, the talking cure by Freud and Breuer. Before we go on to talk about kind of what psychotherapy looks like today, having grown from what Freud started in the late 1800s in Europe, I want to get some terms straight, kind of fill in some of the context in which psychotherapy occurs. One of the things you hear often is you hear psychotherapy and counseling used essentially almost as synonyms. And I guess in practical terms, it wouldn't be incorrect in the general sense to use them synonymously or nearly synonymously. In reality, traditionally, the distinction has been that counseling interventions take as their focus this person. Everybody has certain strengths, certain things they're good at. If we take those things and we accentuate them and we build on them, we can improve the person's circumstances. And if we improve those circumstances sufficiently, we can alleviate their suffering. So counseling would be a health-based, strength-based sort of an approach. Psychotherapy traditionally was this person is coming to me with a problem, let's figure out the source of the problem and resolve it. That distinction was clearer, 50 years ago. I would say practical intervention, so people who are actually involved in providing counseling, the recognition on a pragmatic level is that of course you have to sometimes address, somebody comes to you and they've got relationship problems, their dating life is a mess, and they're bright and attractive and articulate and they're funny and they've got all these assets, and yes, continuing to work on social skills and work on decision making and that kind of thing is that's a good thing, and definitely all more power to you, do that. But there comes a point just pragmatically where you look at it and you go, well, you're talking to a woman, you've got a master's degree in mathematics and you're a very very physically attractive woman who comes from a relatively well-to-do background, and you're dating guys predominantly who are unemployed and drug addicted. It's probably not going to work out, right? So there come times where even in counseling where you're focused on strengths and assets, where the problems, the most efficient course is to have a problem addressed. And then conversely, psychotherapy, where the tradition is that you're problem focused, has learned well from counseling approaches, and that is working from the position of what the person is good at tends to increase the likelihood of success. Building on somebody's strengths, expanding their assets psychologically, socially, this sort of thing, does tend to promote happiness. So while there is somewhat of a distinction still, the fields are actually fairly close. Psychotherapy and counseling are actually very similar. In terms of the people who are providing psychotherapy and counseling, I'm going to go through this, and I think this is useful because the reality is, if you don't, and the odds are that you at some point probably will need to talk to somebody because life can be very, very, very difficult. If you don't, the odds are that somebody you care about eventually will need to talk to somebody, and knowing kind of who the different players are and what the different things that they offer are can be helpful to know. So there are essentially 4 general levels, so to speak, of accreditation and licensure training. So generally we think of, at the top of the pyramid, people who are physicians, people who have either a medical degree, they're medical doctors, MD, or they're doctors of osteopathy, DO. The distinction is that the DOs come from a background, that the training background for DOs is more kind of holistic. In a pragmatic sense, nowadays, not much of a difference between the two. It used to be that an MD had much more kind of authority behind it, but the reality is today there's essentially no difference between an MD, a medical doctor, and a DO, a doctor of osteopathy. They're both physicians. A psychiatrist is the physician level. So they are a physician who practices in the field of mental health. By and large, the vast preponderance of prescribing of things like Zoloft and Prozac and Trazodone and these kinds of things, antidepressants, anti-anxiety agents, antipsychotics, almost all of that is prescribed by a psychiatrist, occasionally by a psychiatric nurse practitioner, which is kind of a level or two down, or a psychiatric physician's assistant. So basically it's MD-DO, physician's assistant, nurse practitioner, RN, on down, in terms of how able they are to practice independently. So you have some prescription privileges at the physician's assistant and nurse practitioner level. So some prescription of psychiatric medicines that we call psychotropics does come from a nurse practitioner or a physician's assistant. The reality is most of it in the mental health area comes from psychiatrists, MDs or DOs. In the broad scheme of things, the vast preponderance of the prescriptions, especially of SSRIs and related medicine classes, things like fluoxetine, which is Prozac, and sertraline, which is Zoloft, duloxetine, these kinds of things. Most of those prescriptions actually come from primary care physicians. But as the psychological problems of the patient become more complicated, the more likely it is that they get referred to a specialist who generally is a psychiatrist, occasionally as a physician's assistant or a nurse practitioner. The reality is, in this day and age, most psychiatrists spend most of their time essentially functioning like a psychiatric pharmacologist. They spend most of their time prescribing and managing psychiatric medications. Historically, they did psychotherapy but you don't see very much of that anymore. And the reason for that is, well, okay, think about it. There's two reasons. The first one is there's two reasons, both of which are financially related, I guess you could say. Just on a pragmatic level, doing psychotherapy at the extreme brief end takes about a half an hour. More generally, you're looking at 50 to 115 minutes, usually right around 50 to 60 minutes at the most. So that means, if you think about it, if you're doing psychotherapy, you can reasonably see no more than maybe 8, maybe 10 people in a day. If you're seeing everybody for approximately an hour, you see 10 people, that's a 10-hour workday. That's a long workday. A psychiatrist, on the other hand, can see the initial time that you meet with a psychiatrist, you may meet with that psychiatrist for an hour or even a little more than that as the psychiatrist gathers the background information and gets a sense of what's going on so they know what medicine to prescribe. Once they do that, though, and they've got you started on a medicine, they know your background, the subsequent visits might be for no more than 15 minutes. That means once they've established a patient, once a psychiatrist has established a patient in medication management, they can see 4 patients an hour for 8 hours. And I'm really bad at math, but I think that's like 32 patients a day as opposed to 8 to 10 patients a day for somebody doing psychotherapy. So in the sense of doing the greatest good for the most people, it makes sense. The other thing to keep in mind is that this is their job, and the compensation rate for a psychiatrist for a 15-minute visit might be anywhere between, say, $50 and $75, $100 an hour for a 15-minute meeting. 35 at the low end, 100 at the high end. So you're looking at a very healthy income if you're seeing anywhere from 25 to 35 patients in a day. There's something else I was going to mention about that. The other variable here is this. What we have found in research is psychotropic intervention is essentially the same in terms of effectiveness as psychotherapy. Both of them work quite well. Interestingly, combining the two of them works better than either one of them do. I think I'll say this. Psychotherapy works very well. It's very effective. We know this. The data is very clear. Psychotropics, psych meds work very well. The data is very clear. You would think if you put them together, they would work maybe twice as well. But the reality is it's like they augment each other and you get a much stronger benefit. So the reality is if somebody is experiencing problems with, say, depression, anxiety, something like that, psychotherapy will work for it, psychotropics will work for it. What works even better is a combination of the two, taking a psychotropic under good supervision and getting involved in some sort of psychotherapy, generally speaking, not even for very long. I got to step away for 1 second, so I'm going to pause this and I'm going to come back and talk about the people who provide the psychotherapies and the counseling, psychologists, social workers, and therapists. Okay, so physicians, MDs and DOs, full prescription privileges, spend most of their time, psychiatrists, spend most of their time practicing medicine in the sense of managing medications. Physician's assistants and psychiatric physician's assistant and psychiatric nurse practitioners have more restricted prescription privileges. In other words, there's some medicines that they can't prescribe, but they do have that option. Generally speaking, the medical professionals, psychiatrists, nurse practitioners, psychiatric nurse practitioners, psychiatric physicians assistants don't generally do a lot of psychotherapy, although psychiatrists certainly get that training in their residencies. The highest ranking, I guess you could say, in terms of licensure level, capacity to practice independently, and generally um, longest time spent in school would, among the people who actually spend most of their time doing psychotherapy, would be clinical psychologists, people who have either a PhD, a doctorate of philosophy, or a PsyD, a doctorate of psychology. That's, for what it's worth, that's what I have. I'm a PsyD. Or an ED, which is a doctorate of education. People with EDs generally are practicing in school settings, so their training is specifically as a school psychologist. So they're doing psychotherapy in those settings. PhD PsyD, they are fully independent as far as doing psychotherapy, doing psychological testing, personality testing, IQ testing, things like that. For the most part, they don't generally have prescription privileges. There are some exceptions in the military. I believe there are a few states where psychologists have limited prescription privileges. A PsyD and a PhD in terms of actually practicing psychology are essentially synonymous. The training is where they differ. Somebody who has a PhD has a bit more training in doing research. In order to get a PhD, you have to complete a dissertation. The PsyD is an entirely applied degree, meaning you spend all of your time in graduate school learning psychotherapy, learning testing, and a relatively smaller amount of time doing research. You're taught to consume research, being able to read it critically and understand what it's about, and understand statistics and statistical analysis, that sort of thing. But you don't spend nearly as much time in a PsyD program actually doing research. Also providing psychotherapy are social workers. Most social workers are either licensed clinical social workers, LCSW, or master's level social workers, MSW. Occasionally you will get DSWs, doctorates of social work. A lot of the distinction is again, how long you spend in school. Do you do a dissertation as opposed to a master's thesis? Generally speaking, social workers have independence in practicing psychotherapy. They tend not to spend as long a time in school as psychologists, with the exception of the doctorate of social work, which is comparable. That being said, some of the best psychotherapists that I have known have been social workers at the master's level. And then working your way down in terms of capacity to practice independently and the time spent in school, therapists and counselors with a master's degree, a Master of Science, MS, or Master's of Arts, MA. There are also something called a licensed marriage and family therapist, LMFT, where they go to school specifically to do marriage therapy and family therapy. That's specifically where they're trained. It's generally a 2-year program. Most master's programs are 2-year programs. In most places, most states, because you're licensed in each state. So somebody who's licensed as a psychologist or a social worker or a therapist in Georgia, they decide they want to move to Montana, they have to get licensed in Montana separately. But in most states, master's level therapists require some degree of oversight or supervision by somebody at a higher level of licensure, generally a psychologist or a doctorate of social work. So that's the breakdown. And again, same kind of thing applies. While the doctoral level psychologist has more training, the path there is academically more rigorous. It's more difficult to become a psychologist than it is to become to get into a program to become a psychologist than it is to get into a program to become a social worker or a therapist, master's level therapist. Just like I was saying about social workers, actually the 2 best psychotherapists that I have ever seen, one was an LMFT, a licensed marriage and family therapist, and the other one had a Master's of Arts in therapy. And they were both fantastic therapists, much better at it than I am. So that's the rundown. Okay, basics of psychotherapy. I'm going to hit each of these bullet points relatively quickly. The first thing that you need to understand about psychotherapy from a general perspective is the idea of the frame and what we call the frame and boundaries. Basically, the frame and boundaries are the setting and the rules under which psychotherapy is practiced. So this is like, the frame is everything from like, how often do you meet? For how long do you meet each time? Where do you meet? Do you meet in a home office in the psychotherapist home, which is a little unusual? Do you meet in an office within a medical practice? Do you meet in a private practice office? And then other things that are more unique, things like, what are the rules by which you interact with each other? What do you call each other? Therapists spend a fair amount of time thinking about things like, what message am I giving? This is part of the frame. What message am I giving to my patients depending on how I dress, whether I wear a wedding ring or not, how much makeup do I wear? Do I wear, what kind of jewelry do I wear? What kind of pictures do I have up in my office? And you can see, you can imagine how significantly it changes things. Say you have a therapist come in and they're basically in their psychologist uniform, right? Like that cliche of if it's a guy, a tie and a vest and a coat with the little sleeves, the patch sleeves, and he's got a beard, and he's got little round glasses, and as opposed to I don't know, a hippie chick, a woman that comes in and she's got gray hair and a braided ponytail, going down to her waist, and she's wearing a big long flowing skirt and sandals and bangles on her wrists and rings on her fingers, and she comes in and lights some incense, whereas the other guy, who's the traditional psychologist, comes in and he sits in his big armchair and crosses his legs and lights his pipe, and those are dramatic and kind of silly examples, but you can imagine that profoundly changes the context and your expectations for what's going to happen in that psychotherapy, right? So this is the kind of thing that the frame is referring to. Boundaries are like a subset of the frame, right? Boundaries are how are we expected to behave? To what degree are we friends? To what degree is the psychotherapy specifically restricted to a professional relationship? What do I call you? When can I call you? What do I do if I see you outside of the office? These kinds of things, right? So basically, they're the rules by which the psychotherapy is kind of contained in a certain time and place. And some of the big things, one of the general kind of rules of thumb is that the psychotherapy is obviously a professional relationship. It's somebody's job to do psychotherapy. The psychotherapist, and this is a good thing, this sounds like a bad thing when I say it, but they're not your friend and shouldn't be your friend. And this does not mean that it's not important. It's kind of like saying a parent isn't your friend and shouldn't be your friend. Their job is more important than that. In the case of psychotherapy, the problem with friendship in psychotherapy, and I'm making a distinction between friendship and affection. Good psychotherapy is characterized by affection. You care about the person. You have warm feelings toward them. But a friendship, one of the characteristics that define a friendship is a degree of equality. If I'm your friend, my job is to take care of you, and your job is to take care of me. And there's some degree of equalness, of equality. And often a shared interest, shared activities, we spend time together across time, and any gain in the relationship is mutual and complementary. Although I guess you could say that about psychotherapy also. But the instant you start paying somebody to be your friend, they're not your friend anymore. And the reality is, if somebody comes in and is going to be a patient in psychotherapy, you're expected to pay, or your insurance pays, and so it's not a friendship. This is important because while the goal of psychotherapy is to alleviate psychological suffering or behavioral suffering, One of the things you have to be prepared for in psychotherapy is that often what your job is not to necessarily make the person happy. There are times in a psychotherapy where you're having to do and say things that actually will lead to a fairly significant degree of unhappiness. A man comes in for help with depression, and in the course of the psychotherapy, it becomes apparent that his marriage is in trouble, and it turns out his marriage is in trouble because he's a jerk. He's mean to her. His welfare comes down to helping helping him, you as the therapist, helping him recognize that he's being a jerk. And that may lead to some hurt feelings in the short term. You have to be careful about how you go about that, because if you so hurt the person's feeling that they withdraw from the psychotherapy, you can't do much to help them. But the more important component of this, because that does sometimes happen in friendships too, right? Sometimes you gotta take a tough love approach with a friend. The more important piece of it is that in the psychotherapy, the patient has no obligation to take care of the therapist other than to pay the fee. The psychotherapist actually has considerable responsibility for the welfare of the patient, up to and including their physical safety. If I have a patient who suicides, I bear some liability for that, both morally and potentially professionally. Whereas that isn't the case in a friendship situation. So, and the other piece of it is that in order to be a therapist, in order to sustain yourself over a long period of time, if you're becoming friends with patients, and the patients, and this is part of the boundaries thing, feel free to call you at all hours of the day and night, and interact with you on a much more personal rather than professional basis. You can very quickly get to the point where you don't have a personal life, where everything about all of your days is centered around the psychotherapy relationship. I'm trying to think if there's anything else I want to make sure I mention about the frame and boundaries. I'm sure there are things that I am missing. The other thing is, one of the things when you're doing psychotherapy, one of the reasons why we talk in terms of the frame, of making sure you've thought through carefully exactly, the physical setting and when you meet and how long you meet and all those kind of things, is you want to have some consistency. Say you meet with a person once a week for 50 minutes. You meet with them in your office. You want to have a degree of consistency. You want to have a degree of consistency in that context. You want to have a degree of consistency in terms of how you present. You can't come in one day in a suit and then come in the next day in board shorts and flip-flops. I mean, you can, but you introduce some variables to the psychotherapy, because you come in that's maybe you've been coming in a suit and tie. If you're a guy, you're coming in a suit and tie and your beard for a long time, and then you're going to go surfing one afternoon. So you come in tank top and board shorts and flip-flops. But they've never seen you like that before, and it would be understandable if it kind of changed how they thought about you, it can't change how they reacted to you. Well, as the therapist in that situation, I don't know how much of the change in this person is because of me, and how much of the change in this person is because of something in their life or something they're wrestling with. So some degree of consistency is important, so that what you see going on with the patient, you can be fairly sure doesn't have anything to do with you, or has minimally to do with you. So anyway, bear in mind, this one slide here is essentially the summary of at least a 3 credit hour class, right? You can spend an entire semester talking about these things. So I am going to skip over a lot of details. Already have. One of the things to bear in mind about psychotherapy is that a significant piece of a significant percentage of the effect of psychotherapy, the benefit that a person gets from psychotherapy, comes down fundamentally to, do I like my therapist? Do I trust my therapist? Do I think that the therapist likes me? Do I think the therapist is devoted to my welfare? And to what degree do I see the expectations of the therapist as consistent with my expectations? Does a therapist want for me what I want for me? And if those 5 things are all kind of in sync, you like each other, you get the sense the therapist cares about you, is devoted to your welfare, and that his or her goals for you are the same as your goals, those variables count for almost all of the benefit that's shown. I won't say almost all, more than half the benefit that is shown, that is shown in research for psychotherapy, and the benefit from psychotherapy and research is pretty significant. So that's an important thing to recognize. This means that if you go out and you seek psychotherapy, it's very important to find somebody that you connect well with. It's very important to find somebody that you feel like really understands who you are. And then conversely, if you're the psychotherapist, it's important that you get good at connecting people with people in this way. That you do genuinely develop the ability to understand people from different perspectives. Probably next on that list in terms of things that actually help in psychotherapy is insight, is actually the person learning something about themselves that they didn't necessarily know before. What I was talking to you before about with the glove anesthesia for the women, for the hysterical females in the 1800s, presumably the curative factor there, one was, I would assume based on what we know about Freud and his reputation, was they probably thought this doctor actually cares how I'm doing, so that was definitely a part of it. But then the other piece of it was that when they came in, they didn't know why their hand was numb. This had happened, their brain had done this, and they didn't understand the connection. And interestingly, once the connection was made and some reassurance was provided, the symptom went away. So we know that insight is important. If you come into a psychotherapist to see a psychotherapist because your relationships keep falling apart, and it turns out that you're actually doing things that make the people you're dating see you as excessively controlling or excessively needy. Achieving insight into that matters tremendously, right? Like otherwise, how do you change it? So insight very much matters. It can be things as mundane as that, as you're inadvertently sabotaging yourself in relationships, and it can be things as esoteric and exotic as glove anesthesia, and there's all sorts of examples of that kind of thing. Generally, when you see psychotherapy depicted in movies, that's the person achieving insight, the light bulb going on, and they realize something new about themselves. That's generally in the movie where the psychotherapy kind of ends. Then they go on and they have a different life and everything is so much better. That isn't the way it works in real life. The most substantial, the longest portion of psychotherapy, of insight-oriented psychotherapy, where people are coming in and learning more about who they are and what motivates them and so on and so forth, isn't actually the achievement of insight. That often happens, not infrequently, it happens fairly early in the psychotherapy. Most of the psychotherapy then is, like say the person who is sabotaging their relationships because they're coming across as needy. And they never knew this. They don't see themselves necessarily as needy. And so that you figure that out together in the psychotherapy, and the person's like, oh my gosh, I never realized this. And the therapist helps them come to recognize, wow, this really is a pattern. Then you have the challenge of what we call working through. How do you go about, now that you know that, how do you go about changing that in your life? And that can actually take a fairly long period of time. Maybe part of what you got to figure out is, where is it coming from? Is the person maybe not as confident and secure as they like to think of themselves as being, and other people can see this quite easily, say, perhaps. And sometimes, it takes, if that is the case, let's say, it takes, okay, well, where did this come from? And they talk, and you talk about it, and you come to recognize that it is in some degree, it's something that has been there for most of your life, and it's partly a function of the way your family treated you, and they were very loving and supportive, but They also kind of sheltered you and protected you excessively, and the message you got from that was that you probably weren't really capable of taking care of yourself, and blah 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 blah. Okay, so now that you recognize that, now you gotta find some way of being a little more assertive and independent from your family, or assertive with and independent from your family. So you can see how this working through portion of psychotherapy actually sometimes can be the bulk of the psychotherapy, often is the bulk of the psychotherapy. Last two things in our crash course of what psychotherapy actually looks like is the importance of empathy. And this kind of goes back to that curative impact of the relationship. One of the important variables in the importance of the relationship is, do I feel understood by the therapist? And what we find is that when patients feel understood by the therapist or the counselor, the odds that they're going to improve increase dramatically. Sometimes just because they felt understood. And if you think about it, that's characteristic of nearly all intimate relationships. That's the valuable thing. My friends get me. My family gets me. They understand, and I guess part of empathy is they understand and they accept me even if they disagree with things that I might do or think or sometimes the way I behave, that sort of thing. They get me and they accept me. They love me. They care about me. That is curative. It's not the whole picture, but it's a major portion of it. And part of communicating empathy, developing empathy, is the capacity for what we call in the field active listening. And active listening is just all of the cues, the nonverbal cues and such, that we use to communicate to somebody that we are intensely invested in what they're saying. So it's things like good eye contact, and you kind of, I'm breaking this down, and hopefully you're not, as a psychotherapist, you're not sitting in the office thinking about these things. Hopefully you're doing them fairly naturally. But active listening comes down to, body posture. You kind of lean forward and you kind of, you do the dog thing where you kind of tilt your head and you make good eye contact, and you make kind of reassuring noises. And as they're talking, and that is like, okay, keep going, and maybe a little smile. It also involves some degree of reflection, so the person is telling you about a difficult childhood, and periodically, when they pause, you give back to them, you repeat back to them a paraphrased version of what it is that they're telling you. And you're doing that essentially to make sure I'm reading you right. I'm hearing you accurately in what you're saying. This is what I'm understanding that you're saying. And interestingly, that's a part of building empathy. What you want is you want the person going, yes, exactly. That's exactly what I'm saying. Or yes, you get it. And again, just that process of really having somebody listen to you with some degree of intensity, not just to the surface stuff you're saying, but what's going on underneath, so we can help you develop some insight, develop some additional understanding of yourself, and truly understand you from your perspective, while also kind of holding in reserve the ability to see you with some degree of objectivity, see you to some degree as other people do, and help you recognize that. And the person still cares and seems invested and seems affectionate toward you, seems to like you. And I don't mean affectionate physically. That's part of the frame. You don't tend to, a handshake perhaps in rare instances, in fairly constricted instances, perhaps some other expression of physical affection, but those tend to be very limited because of how much they blur the boundaries between a professional relationship and a friendship. But anyway, like I said, there's just so much material here in terms of the basics of doing psychotherapy. I'm giving you, a 20-minute summary of something that's a whole semester at least. Literally books and books and books have been written about this. Okay, one thing I'll mention is that I in the PowerPoint version of this lecture, not this one, but just the PowerPoint slides, somewhere in here there's a slide that has some YouTube links on it. The YouTube links are to clips from the movie Good Will Hunting. And they are depictions of various aspects of psychotherapy. Feel free to watch them if you want. They're not going to be included on the exam. Generally speaking, if we were doing this lecture in person, I would show you the clips, and then we would talk about kind of what's realistic in the clip and what's not realistic. What's the therapist? Robin Williams plays a therapist, and Matt Damon plays a patient. Kind of what's going on there. How does this reflect actual real psychotherapy? That's not something that is easy to do in this sort of a setting. So I'm gonna defer on that. If you're a psychology major and this stuff is interesting to you, there's a class that we offer. I'm actually the one that teaches it on doing psychotherapy, and one of the things that we use in that class is you actually have to watch that movie, and we talk at some length about what's going on in the psychotherapy there as an example of the practice of psychotherapy. So I'm not going to say much else other than that. You're not going to be tested on those clips. Don't worry about watching them if you don't feel like it and if you don't have time. What we'll do is we'll finish up this lecture with me running just real quickly through the biggest schools of thought in terms of how do you actually think about people, conceptualize what causes trouble for them, and then actually go about helping them. I'll mention just the bottom of this list on this slide, or this bulleted list, medical. We're not going to talk about that at any particular length because it's predominantly medicine-based. It's the use of psychotropics, everything from SSRIs, SNRIs to TCAs, different classes of medicines to help alleviate, to help address the physiological underpinnings and alleviate distress associated with anxiety, depression, psychotic features, etc. Promote sleep for people with insomnia, those kinds of things. So we're not going to talk much more other than just identifying that piece of it, so I'm not going to give you a whole separate slide on that. We will start first, though, with the insight-oriented psychotherapies. And I already kind of spoke to this. The focus in these approaches is to bring into awareness things that the person does not know about themselves. And sometimes this is simple ignorance. They just aren't aware, perhaps, of, say, the impact they have on people. But other times it's things like, I don't know whether I mentioned this one before to you, but I had a patient come in who suddenly developed a fear of heights, very, very, very intense fear of heights, out of nowhere after a long career of very, very high risk activities that included a career and hobbies that included skydiving, combat, mountain climbing, rock climbing, scuba diving, all sorts of things like this. So this is a intense, achievement-oriented, risk-taking kind of guy. Sometime in his, about my age, he suddenly went from being, a pretty daring guy to developing very quickly such a strong sense of fear of heights that he literally could not get on a stepladder without becoming kind of dizzy and disoriented, having kind of a vertigo experience. And the long and the short of it was, he had at one point on active duty an event happen when he was doing a jump in which he nearly died. And apparently, what we know the event happened because we went back in records. We got access to records, and we went back and we looked, and there was documentation that there was an accident that occurred. He nearly killed him and one other guy. It was apparently so distressing, so frightening, that the way that his brain handled it was it essentially said, with the memory of the event, yep, nope, we're not dealing with this. And it the term we use in psychotherapy is it repressed it. We talked about that earlier in the semester. That defense of, I'm going to hide this from myself without even knowing I'm doing it. And so that worked for a long, long time. He repressed it. He didn't have any memory of it. He went on doing his jumps. He went on doing his mountain climbing, all of these risky activities. As he got older and he began to become, as most of us do, you become a little less of a risk taker. He settled into a fairly sedentary lifestyle. And then all of a sudden, seemingly out of nowhere, he developed this fear of heights. And the long and the short of it was, we figured it out. We figured out that what had happened was this was all nicely and neatly repressed, held in his unconscious, so held outside of awareness. And he got a call from somebody inviting him to a reunion of his unit, the military unit that he belonged to. And it turned out the guy that called him for the military unit, two things happened, two variables. One, the reunion was actually going to be at the base where the jump took place, where he almost was killed. And two, the person who called him to tell him about it was the other guy who was, just coincidentally, was the other guy who was involved in the accident and also was nearly killed. And that was enough to kind of stir up that memory. It didn't bring it all the way back into awareness, but what it did do is it brought it back enough that he had the emotional response that he had in the original event. And once we were able to piece this stuff together and help him remember, help him achieve insight into that original event, the fear of heights dissipated actually relatively quickly. He had to do a little bit of practicing and such, but once the insight was achieved, in that case, that was a rare case where the insight itself actually did a lot of the work. So the insight-oriented psychotherapy focuses on bringing into awareness drives. So that these are the urges that you have that may or may not be acceptable in a civilized society. So it might be, I don't know, you have long-standing problems with your brother or your sister, and it fundamentally comes down to an intense but unconscious aggressive feelings that you have toward that sibling. This is not an unusual sort of a thing. You're the older sibling, they were the second born. Early on, you developed jealous and aggressive feelings. You were quite young when that second sibling was born. All of a sudden, that younger brother or sister was getting all sorts of attention that used to be just for you. Obviously, you would resent that. You would want them gone. And if you're like most young children, at some point you're excessively careless with that sibling. You inadvertently hurt the kid, or come close to hurting the kid, and you get strongly rebuked by the parents, and they get really mad at you, and they protect the kid, and so you learn very quickly that I have to hide this hostility that I feel, and if you're taught to feel enough shame about it, you might even hide it from yourself, and then later find apparently legitimate reasons to be mad at that sibling and to resent that sibling for other things other than just existing when you were little. And so the drive would be that part of all of us, that aggressive drive. And the psychotherapy would be focused on let's understand what everything that's going on between you and the sibling, and part of that would be helping the person come to terms with some of the kind of the animalistic feelings that they might have. The other aspect, other thing that insight-oriented psychotherapies focus on are existential concerns, and we'll talk about that on the next slide. I think it's on the next slide. But yeah, so insight-oriented psychotherapies are focused on helping people recognize things that they're missing about how they're interacting with people, how they think about themselves, how they think about their world, how they respond emotionally, help them understand their emotional responses. And it generally does this by looking at what led to where you are now. Let's understand where it came from, and that way oftentimes that learning where it came from gives you a little bit of an emotional distance from what's going on and gives you the space to kind of begin to understand it and figure out how to deal with it. Okay, so what I've described to this point in terms of insight-oriented psychotherapy is kind of general approach, general way of thinking about it from most of the perspectives. Insight-oriented psychotherapy, especially drive-focused psychotherapy that's based on the idea that often our problems come from difficulty managing our sexual and aggressive drives, originates with Freud and his followers. And so most of what I've been talking to you about so far is really kind of coming from that perspective. There are two other broad kind of subheadings under insight-oriented psychotherapy. One of them is what we call existential psychotherapy, and that focuses on kind of the big problems in life. And I'm talking about the overarching problems in life. The importance of finding meaning and purpose, and the difficulty in finding meaning and purpose in life. The burden of responsibility in life, and responsibility is all tied up in loneliness, frankly, because the degree to which you are independent and responsible for yourself is related to the degree to which you are alone. Responsibility, well, we think of it as just as a positive thing, independence and responsibility as positives, but they come with a cost. And so the part of the existential psychotherapy is dealing with that balance. And then, of course, the other variable, major point that the existential psychotherapies focus on are related to our mortality, the reality, I should say, the impact of mortality, the reality of our own deaths. The existential psychotherapy has made a valuable contribution in recognizing that our efforts to avoid awareness of our own mortality, of our own impermanence, can significantly complicate our lives. And conversely, coming to terms with the reality that I am going to die. It's very real. I'm here only temporarily. I'm here for a limited amount of time. That can be unbelievably anxiety provoking for somebody when they recognize that for the first time. But it can also be, conversely, very freeing for somebody. You can have, in fact, I've had a number of patients who came face to face with the reality of their own deaths, either by a serious accident or by having somebody they love die, or a serious illness or something like this. And they often come into psychotherapy because that creates such anxiety and distress in them, so as to almost immobilize them. And as they work through it, and we talk through, and we kind of take account of where they are in their lives, why death is so frightening, other than the obvious, it's the unknown and that sort of thing. But people have individual reasons, relatively unique reasons why death is frightening for them. And oftentimes that's never been thought about. In fact, it's been actively avoided. Helping people work through those things, recognize and accept their impermanence, that being confronted with that can be anxiety provoking. Working through it actually can be very freeing, because all of a sudden you're not pretending like you've got forever. Pretending like you've got forever is denial that you're going to die. Directly or indirectly, it's denial. And what happens when you come to terms with the reality that you're going to die, and you're able to confront it and accept it, that lends some urgency to your day-to-day circumstances. It also lends some richness to your day-to-day circumstances. I'm not going to think about how it would change things, how much more you would value, say, somebody in your family if you found out they were terminally ill. You don't have forever with them anymore, and it's real, and you know it. Well, the reality, the awareness, the recognition, and the acceptance of the reality of our own death on a day-to-day basis, of our own deaths on a day-to-day basis, can have a similar effect in terms of enriching your life, enriching your day-to-day experience of things, making food taste better, making, heck, even making pain more tolerable. Because in order to feel pain, you have to be alive, right? So existential psychotherapy, fascinating way of looking at things. It's basically helping people cope. They believe the existential psychotherapy is essentially arguing problems generally come up when you try to pretend like the big problems in life aren't real. And the psychotherapy is focused on helping people to come to terms with, directly confront, and accept and integrate into their lives these big problems, these big questions. And then the third of the insight-oriented psychotherapies is not so much a different perspective on where the insight needs to happen, but instead kind of an integration, like we were talking about the distinction between psychotherapy and counseling before. It's kind of an integration of the Freudian psychoanalytic psychotherapies were fairly pessimistic, especially about the human nature. They saw people as fairly animalistic. It was a very deterministic framework, very past-focused, and like I said, it kind of assumed animalistic motives for people, very selfish, base motives for things. It also tended, not exclusively, not all of the people who were psychoanalytic theorists, but many of them were either atheist or agnostic, and saw people in entirely material terms. The humanistic psychotherapy is essentially taking that insight-oriented psychotherapy and emphasizing the idea that there may be more to us than just our pathology. That we aren't, that we are animals, but there's something special about the human animal. Certainly consciousness, the moral obligations that are associated with consciousness, this sort of a thing. And the humanistic approaches are responsible really for the emphasis on the active listening and the empathy and the relationship that I was talking about earlier in the lecture, in terms of how profoundly they have a positive effect on the patient getting better. So the humanists kind of saying we're not just our drives, we're not just our fear of death. There's more to us than that. There's, we're not just our past. There's things pulling us into the future. There's hope and the desire for achievement. That is the humanistic perspective. So those are the insight-oriented psychotherapies. We'll talk real quick here about the behavioral approach. We talked earlier in the semester about learning theory, conditioning, classical conditioning and operant conditioning, social learning theory, these kinds of things. Basically, behavioral psychotherapy is the application of learning theory. And it's essentially the idea that if we create behavior change in people, if we get people to behave differently, to go about their lives differently, we could, well, surprise, surprise, we can change the course of their lives. And if you change your behavior, we can make you feel better. And some of this stuff is absolutely indisputable. I mean, the most effective treatment for depression and anxiety is, I've said this before in here, sorry I'm a broken record, but you can alleviate the preponderance of the suffering associated with depression and anxiety by helping the person sleep 8 hours a night, helping them eat a healthy diet that minimizes alcohol and other substance abuse reduces sugar, reduces refined carbs, and is heavy on fresh fruits and vegetables, healthy lean meats, and healthy fats. And then get them exercising vigorously a minimum of 5 days a week for at least half an hour a day. You do those three things. You institute that behavior change, and you are going to alleviate most of the suffering associated with depression and anxiety. So this is a very, very real and very practical way of looking at things. Similarly, if you have somebody come in and they're lonely because dating hasn't worked, and so you sit them down and you coach them through social skills. You teach them to change their behavior. You teach them to eliminate the things that might be turnoffs interpersonally. You teach them the little tools, the little behavioral, the subtle behavioral cues that we see in people who are regarded as charismatic and attractive, and you can change their lives, right? So it's this idea of eliminating or reducing maladaptive behaviors, teaching adaptive behaviors, productive behaviors. Like I said, very focused, very pragmatic. You come in, what is your problem? Let's fix that problem. And we conceptualize the problem in terms not of how you're feeling, not what you're thinking about, what are you actually doing, and let's get that to change. One of the things that behavioral therapy in particular is useful for is reducing anxiety, reducing phobia responses, and we do this with systematic desensitization. If you have something that is very, very frightening for you, if you have something of which you are phobic, for example, or if you have a trauma that happened that is incapacitating now because you can't let it go. Systematic desensitization is basically getting the person in a safe situation, teaching them to control, to settle their body down, relaxation, deep breathing, that kind of stuff, and then presenting them in a controlled way with the things that scare them. And each time they get this arousal response, this physiological response, we get it settled down again. And then we present the thing that scares them to them again. And then we settle their body down again. And we present it again, and we settle their body down again. And eventually what happens is you keep presenting it, you keep teaching this relaxation, and you get to the point where that thing that scares them begins to produce less and less of a physiological fear response. So that's an oversimplification of systematic desensitization. Aversion therapy is, I'll give you the classic example of aversion therapy. You're trying to give up, I don't know, Oreos or cigarettes or whatever, and the classic one is they have you put a rubber band on your wrist, and every time you have a thought about the Oreo, you pull that rubber band back and you let it snap against your wrist, and that hurts. And the idea is that you start pairing the Oreo with all of its positive associations with the negative experience of this relatively incidental, relatively minor pain. And it actually, again, works pretty well. And then we already talked about skill training. So this stuff, again, this is very, very pragmatic. It's useful in sports psychology, in maximizing performance in difficult situations. Sports psychology, any sort of performances, like artistic performances, they use this stuff in the military, that sort of thing. Working with people with neurodevelopmental conditions, Asperger's, autism-related conditions, cognitive disability, or what we used to call mental retardation, where you're actually teaching things like in somebody who's developmentally disabled. Teaching really basic things like how to dress yourself and how to clean the house and how to use public transportation, and so it's pragmatic things like that. It can be things, I think I may have talked about this when we talked about autism in the last class period. It may be basic things like teaching the fundamental building blocks of social skills. The basic do's and don'ts that most of us don't have to think about. We don't have to explicitly learn. We learn them implicitly. We just kind of grow to know these things. Changing behavior in people in those situations can be very productive. And then, like I said, elimination of things like phobias and bad habits and that sort of thing. Very applied, usually fairly brief, very pragmatic, a useful approach generally. Okay, and that brings us to uh, uh, cognitive behavioral therapy, CBT, as it's commonly referred to. Of the three basic schools, general approaches, CBT, cognitive behavioral, and the related techniques are probably the most prevalent and most popular. That's in no small part um, because they have been well demonstrated empirically. There's good research support for this way of doing things. The problem with insight-oriented psychotherapies is they're heavy in kind of the art of psychotherapy. They also require considerable background and learning in some fairly complex theories about how the mind works. Whereas cognitive behavioral therapy is a little more straightforward, is a little less. I mean, it's still psychotherapy, so there's still an art to it, but because it's empirical, it's much more kind of methodical. You know, it's an easier thing to teach in terms of here's step one, here's step two, here's step three. In order to do research about psychotherapy, you've got to be able to break down the psychotherapy like that, because you got to be able to show we go and we use this intervention, this type of psychotherapy, and this type of psychotherapy means we do A, B, C, and D. And when we do A, B, C, and D for this amount of time in this order, for this long, that kind of thing, we get a benefit. This is how much the patient improves, right? So you have to do that in order to demonstrate that it works, right? You have to operationalize the approach. Well, when you operationalize the approach, essentially what you're doing is you're breaking it down in such a way that it becomes a little easier to teach. So it ends up being very, very, very popular. The fact that there's all sorts of data supporting the fact that it works doesn't hurt. Although what we are finding is that insight-oriented psychotherapies tend to be every bit as effective. They just tend to be a little more difficult to do research, especially empirical research, to support. And what CBT basically is doing is taking the behavioral approach that we were just talking about, and it is integrating with it, making cognitive changes. And I'll put it to you like this. The way that a cognitive behavioral therapist might say it is, you got three components. You got three legs to the stool of the human psyche. You have behavior, you have cognition or thinking, and you have emotion. And if you can change any two of those, you'll change the third. Well, the problem is as I've said to you here before, you don't really have a lot of control over how you feel. The emotions happen to you rather than you choosing them. Cognitively, your thoughts are under relatively greater control, but it's certainly not complete control, right? Because everybody has times where you start thinking about things you don't want to think about. You know, especially if you're laying in bed at 2 o'clock in the morning thinking about, the reality of your own mortality and the existential perspective. So we have greater control over thinking than we do over feeling, but still not complete. And of course, behavior, we have probably the greatest degree of control. You can, even though sometimes it doesn't feel like it, you can choose to do something or choose not to do something pretty reliably. And so what they're saying is, if you can help a person change their behavior and become aware of and change the way they think, you will impact how they feel. And that's a very, very strong argument. It does tend to work. So they focus on, let's change the way you're going about things. Let's identify the ways in which you think about yourself or others or the world or the future in a way that's false, that's maladaptive, that's non-productive. Let's identify the assumptions that you're making about yourself, the world, the future, these kinds of things that are inaccurate, and let's help you consciously choose to think differently about them. And again, you can kind of hear in the way I'm, you can to some degree, you can turn this into a workbook sort of approach. You can teach therapists how to begin to go about methodically addressing maladaptive beliefs, problematic automatic thoughts, this kind of thing, instituting behavioral change. And so you can get very reliable results across a bunch of different kinds of therapists, right? A bunch of different kinds of people. One of the other things that makes it different from traditional insight-oriented psychotherapies is an emphasis on homework, and this is actually, I think, a very positive thing. One of the problems with psychotherapy is if you're lucky, you get to meet with the person 1 hour a week. Well, they got the whole rest of the week for things not to go well, right? If you assign psychotherapy, say if you say, a classic homework assignment is in cognitive behavioral therapy, they're having problems. We're going to go back to the dating thing, or they have problems in their dating life. One of the things that we identify early on is that because they lack confidence in themselves, and we come to recognize that part of the reason why they lack confidence in themselves is they see themselves in an unrealistically negative way. And we begin to confront those negative self-perceptions, those inaccurate negative self-perceptions, and perhaps we give them the homework assignment of, okay, I want you to go home, and at the end of every day, I want you to identify something that you told yourself about yourself that you recognize with a little space is false. Oh, I'm really, I'm the ugliest person in my class. And objectively, you had that thought go through your head, and you get home and you realize, oh, I'm not the ugliest person in my class. There's at least 5 people who are uglier than me, right? Or hopefully more than that. But that's where you stand. You can say that confidently. I know I'm not the ugliest person in the class. And so we give them the homework assignment of going home and identifying the maladaptive belief, writing out the something that is true. The correction to the maladaptive belief, and then perhaps identifying how we might behave differently on the basis of recognizing that this thing is false and that there's a better way of thinking, right? And so what you're doing is you're getting them to kind of begin to implement some of the psychotherapy on a day-to-day basis. So they're not just seeing you once a week or once every 2 weeks. They're thinking about this stuff on a daily basis. And we're also creating a situation where we can kind of monitor, are you making progress? Are you actually changing things? And that's often different. I mean, to be fair, insight-oriented psychotherapies have begun to integrate some of these techniques. And the reality is, if you look at this, the way people practice, behavioral therapists, cognitive behavioral therapists, the various insight-oriented psychotherapists, when you actually look at what they're like, I would say I'm an insight-oriented psychotherapist, but I use behavioral techniques and cognitive behavioral techniques all the time. The reality is, in real life, people practice, there's a lot of merging of these schools of thought. I'm kind of separating them out so you can see the different origins. And two, I don't want to say lesser, but two smaller, less prevalent, though still popular approaches are family systems or systems therapy, or a systems concept, systems theory, and feminist theory, feminist psychotherapy. Systems, and like I said, smaller schools of thought than the prior 3. Generally speaking, they are kind of amalgams. Feminist thought and systems are kind of amalgams of parts of the other 3 major schools of psychotherapy. Systems approaches basically argue that the problems with individuals are a function of problems in a system. So the classic example is, a kid is having problems in school. The assumption from the systems perspective is that if we can address problems in the way that the school is approaching the kid and problems in the way the family is approaching the kid, that the problems that the kid is having with their grades are probably going to be resolved. And the reality is, this actually is this grew initially out of working with people with schizophrenia, because schizophrenia is incredibly difficult to treat. And so one of the approaches we took was, okay, if it's hard to help the person individually, because the person individually, it's like the schizophrenic person individually is not in consistent contact with reality, if instead what we can do is help their family reduce their stress, if we can control the circumstances in terms of stress reduction and improving communication and that sort of thing, helping people around them understand them a little bit better, we can begin to alleviate some of the symptoms of depression. So they found this. They found that actually that it works relatively well, as well as anything else does with schizophrenia. And so they began to look at, okay, if this is true for people with schizophrenia, might it be even more effective with somebody who's a little healthier and a little more capable of acting in their own best interest? And indeed, that's exactly what they found. The reality is, and not infrequently, individuals come in, especially when they're kids, and have problems that are the result of dysfunction from within the family. The system of the family is a problem. And it's not unusual. The other approach this is very helpful for is in marriage situations or couple situations where it may not be that either one of them is the villain, either one of them is the problem. It might be that they're not communicating well with one another, or they're both bringing into the relationship their own dating histories, their own past pains and the ways people have betrayed them and hurt them, and they're making assumptions about each other based on those histories. And part of the way of addressing that then is to help them deal with each other as they are, rather than as they are expected to be, right? So this is kind of the premise of systems therapy. Feminist psychotherapy, feminist theory, is the premise essentially that everything is political, and basically what it's arguing is that suffering by and large is the result of oppression and power differentials, and that if you address oppression, intentional and unintentional, personal and systemic or institutional, you will alleviate psychological suffering. That's not true. I will say one more thing about this. There's a legitimate criticism of this. Feminist theory brings to the forefront something that is valuable. Power differentials do have a powerful influence on a person's capacity for happiness, and identifying what's going on in terms of these power differentials and the assumptions that people make around them is a good idea in all psychotherapy. The criticism that I think is very reasonable, and the reason why I'm not going to spend a lot of time talking about feminist therapy, is that it treats the patient as a means to an end. The goal of feminist therapy is to change society as a whole, to help people recognize the threat and the damage caused by disempowerment and oppression. And the criticism, and I'm nitpicking to some degree, because I'm sure most feminist psychotherapists would say, no, I actually do care about my patients. I want my patients to get better. But the underpinnings of this approach are fundamentally social change. And seeing the individual as a mechanism for instituting broad change, I think, leads to some problems morally. Individuals should be treated as individuals, not as a means to an end, in my opinion. That being said, like I said a second ago, emphasizing the damage that can be caused by oppression and the the damage to self-image, self-esteem, damage to close personal intimate relationships by disempowerment, by power differentials, is an entirely valid way of working and quite valuable. Okay, I'll say this. There is so much ground that we had to leave not covered. There's so many other kind of minor schools of thought. The ways in which I've covered insight-oriented psychotherapies and cognitive behavioral therapy in particular is just barely skimming the surface, man. I mean, there's just so much more to talk about. I'll give just to give you a flavor for it. My background is in insight-oriented psychotherapy, and I had I want to say 11 3-credit courses over the course of my graduate program and a year of postgraduate study in doing insight-oriented psychotherapy. So to say we're not scratching the surface doesn't even begin to cover it, right? So I just want you to recognize this is just a very, very quick summary. This and what's in your book gives you a broad picture. If you're interested in this stuff, if you're interested in the stuff on the chapter on personality theory, there's a class on personality theory that I teach that you're eligible for now that you've completed or once you complete introductory. And then after you complete the personality theory class, you can actually take the psychotherapy class if you're interested in this stuff. So I will leave it at that. Wish you good luck on exams and studying and all that. And it was nice sort of being able to teach you on the days that we actually got to be in class.